The testicle is pushed forward and a prescrotal incision made. We are doing a closed castration, so make sure the tunic is not incised. To tell if a level is tunic or not is to move the testicle forwards and back. The tunic moves with the testicle. First, the attachments are torn at the caudal pole and the fat is stripped away. I often use Alice tissue forceps to stabilize the testicle and stop it flopping around. I used small mosquito forceps to make the crush bed. And now form the millers. Move away the forceps and tighten the millers into the crush bed. You should see and feel the millers dig into the tissue. The mosquito forceps were reapplied to form the next crush bed, in which the second millers will go. We remove the testicle and keep the crush bed on the side of the removed testicle. The inguinal testicle will not easily fit through this incision, so we close the fascia and skin. We close the fascia with a continuous pattern, ensuring all the fat is kept inside of the incision. Now we trim the short tail and use the long piece to go straight into intradermals. Take a bite cranial to the knot, coming out at the end of the incision. This should hold or bury the knot. Again, burial of the skin knot is very important, otherwise the knot sits between each side of the skin. This prevents this area of skin from healing and you can get a breakdown 2 to 3 weeks post-op. Pass the needle very close to the knot, make sure it glides through, if not go again. Lift the skin over so the needle exits the skin quite some distance. Pull on the suture material, but mainly use forceps to push the skin over the knot. Stabilize the inguinal testicle and check there are no vessels, where the incision is going to be. We don't incise through the tunic, so we can keep it as a closed castration. Again, break away the attachments and strip down the fat. The forceps are used to make the crush bed for the first millers, and then we reapply the forceps and place a second millers. We then remove the testicle and close the fat or fascia layer with a continuous pattern. To hold the knot down, so it cannot stick out of the skin layer, we take an abite cranial to the knot and exit right at the end of the incision. Then we close the skin with a continuous intradermal pattern. My end of the suture is very short and difficult to place a threaded needle. My way round this is to place the needle first, then thread the suture and pull through and bury.